Greetings, welcome. I'm delighted to welcome you to the third and final session of our Healthcare Roundtable, COVID-19, Healthcare and Beyond. I am Emily Lynn Osborne, and I am the Interim Dean of the Graham School of Continuing Professional and Liberal Studies. I am also a professor in the Department of History here at the University of Chicago. Today, we are hearing from Dr. Sonia Dinizulu and Dr. Shola Olapade to consider the pandemic from perspectives both local and global. We focus in particular on the effects of the pandemic on Black communities here in Chicago, among youth in particular, and its effects on mental health. The pandemic has coincided with a powerful political moment in the United States, a time of heightened attention to racial injustice and structural racism, and we will explore the consequences of the intersections of pandemics and protest. We then step back from the US to take a global perspective on the pandemic and to consider the trajectory of the pandemic elsewhere and the public health policies that it has inspired. Indeed, if you came early to the webinar today, you heard the approach that one country has taken to broadcasting to the general population information about COVID. In the musical clip that opened the Zoom room, President Weah of Liberia gives a number of pointers to his fellow citizens to wash hands, to look after your intergenerational household, and to go to the doctor if you're sick. At core, this song illuminates the link between the individual and the collective. And this is one theme that I anticipate will come up in various ways today. Before I introduce our presenters and my fellow moderator, Dr. Dorian Miller, a few words about the format of the discussion this evening. This is a webinar. That means that you are not able to use your microphone and your camera is turned off. We are recording this event so that we may post it online for people to watch at a later date. You are able to communicate with the moderators and ask questions of our speakers through the question and answer box. We encourage you to do so. Our panelists will be taking questions from the audience periodically through the discussion, and we will also reserve the last 25 minutes or so of the discussion to Q&A with the audience. We will not be able to answer all of your questions, but we will definitely try. You'll find the button to open the Q&A box at the bottom of your Zoom window. Additionally, we are providing live captioning for this roundtable. If you would like to be able to read the proceedings, then please click on the CC button on the bottom of your screen. If you missed the previous two healthcare roundtables, they are available online, and you may watch them whenever you feel like doing so. Links for those videos will also be in the chat box. As I often say, the Graham School serves as the front door of the University of Chicago. We try to make it a warm, welcoming, wide open door. And today we stand at that door with our panelists and my fellow moderator. Dr. Sonia Dinizulu is an assistant professor in psychiatry and behavior neuroscience. She is a clinical psychologist who specializes in working with children, adolescents, young adults, and families exposed to trauma and violence. She provides trauma-informed and trauma-responsive services using a socio-ecological and social justice lens, particularly for marginalized and underserved youth facing chronic stressors, such as community violence. Dr. Shola Olapade is a professor of medicine and the dean for academic affairs. He is a pulmonologist with expertise and clinical interest in asthma, chronic obstructive lung diseases. He has conducted research on best practices for asthma management, as well as studies on managing household air pollution. For 1/2 of the world's population, the energy poor, his research reveals a ready pathway towards significant gains in health and well-being through use of clean burning ethanol fuels for cooking. My fellow moderator in this series is Dr. Dorian Miller. Dr. Miller is a general internist who has been providing care to underserved minority populations for 30 years. She has a special interest in behavioral health, and she has long focused on community-engaged research and practice that seeks to improve health outcomes for residents on the South Side of Chicago. And I will add, it has been a total pleasure to work with Dorian through this series. I am grateful and would like to thank Dr. Miller, Sinizulu, and Olupade for joining us today. I also want to thank a few people behind the scenes who are helping manage the technical aspects of this webinar and who you may encounter in the Q&A box. These fabulous, thoughtful, and talented people are Jan Watson, Natalie Watson, Nikki Yagoda, and Debbie Thompson, who is our captioner. Many thanks. Dr. Miller, you have a few words to say.
Thank you so much, Dean Osborne, and welcome to.
Oh no.
Thank you, Dean Osborne, and welcome to our guests who are with us from around the world. I am absolutely delighted to be here and to represent the University of Chicago Medicine in this anchor to our series on roundtable discussions, COVID-19, healthcare and beyond. In our first two sessions, we talked a fair amount about the delivery of healthcare at the University of Chicago, and also some of the ethical issues around looking at limited resources. We also had the opportunity to look at the issue of COVID-19 and how it's affecting Black and Brown communities within the city of Chicago. But now I think that our conversation is going to focus on what's going on beyond the walls of the University of Chicago, beyond the walls of community, and thinking about both some of the issues that have taken place within our society and how they've really crashed together in order to create something that Dr. Dinizulu is going to talk a little bit more about in terms of societal issues. Dr. Olupade will talk to us a bit about not only public health perspectives, but also global perspectives on the pandemic. And so what I'd like to do right now is to get started and to start with Dr. Sonia Dinizulu. And Dr. Dinizulu, if you could just talk a little bit about yourself, your background, and your work in this space.
Sure. Good evening, everyone, and welcome. It's such a wonderful turnout this evening. Very excited to present and receive some questions, and thank you for the invitation. So I am Sonia Mathis Dinizulu. I'm a clinical psychologist. I work with children and adolescents and families exposed to trauma and violence, as this was mentioned earlier. My work focuses primarily on providing assessments and treatments with kids. My research work is also working with kids who are exposed to chronic stressors, primarily community violence, as a form of trauma and continuous traumatic stress. And I provide services for that, for people in those communities, as well as, again, the research that I look at is trying to find violence prevention efforts, protective factors that can help promote wellness and prevent violence in youth in out of school time spaces. So meaning in spaces where kids are at outside of school. And then I think there was some discussion before about us talking about how we're operating with COVID in the work that we're doing right now, correct?
That's correct, but we'll come back to that in just a moment. Okay. Thank you. I'm going to turn to Dr. Olupade now. Dr. Olupade, if you would talk a little bit about, introduce yourself and to talk a bit about your work, and then we'll come back to Dr. Dinizulu.
Yeah, good evening, everybody, and thanks for joining this conversation. My name is Shola Olupade, and I'm professor of medicine in the section of pulmonary and critical care at the University of Chicago. I'm a pulmonary critical care and sleep specialist, and I see patients with lung diseases with a focus on obstructive lung diseases, especially asthma. I also teach research ethics and responsible conduct of research at the McLean Center for Clinical Medical Ethics at the university. As an environmental scientist, my research is focused on investigating the interaction between environmental exposure and genetics on the expression of asthma. I also conduct studies to investigate the impact of exposure to air pollution on maternal and child health, both in Nigeria and here in Chicago. I'm looking forward to a very exciting conversation this evening.
Thank you, Dr. Olupade. Dr. Dinizulu, turning to you now, you introduce yourself as a clinical psychologist that does your primary work in the area of trauma. One of the things that I think that we've experienced as a society is certainly the trauma that's been experienced by this pandemic that's been in place now for over a year. But I think that one of the things that our communities are experiencing almost feels as if we've been hit by a hurricane and then the tsunami has come to wash over us as well. Could you talk a little bit about how the framework of COVID-19, in addition to some of the things that are taking place within our communities at this point, have really hit Black and Brown communities locally, and particularly our youth?
Sure. So I want to introduce a concept called syndemics, and this is a really nice way to talk about this and conceptualize this a little bit better. Sorry, I'm going back. I thought my slides were ready. I'm so sorry. So people talk about us having two pandemics, and I think that kind of conceptualization makes sense. However, I don't think it really emphasizes like what are the health interactions that are caused by these two pandemics. So syndemics is a really, really nice construct that talks about what does this interaction looks like. Dorian, what you're saying is we had COVID-19 and then we had some other social uprisings last summer. So I'll talk a little bit more about that in a second, but let's just define what syndemics is. And this is included in a nice lengthy article, two papers that were included as part of this talk that you all can reference to for more detail. But syndemics involves the adverse interaction of diseases. So it could be two or more types of diseases and of any type. It could be mental health. It could be infections. It could be chronic non-communicable diseases. And then you have the conditions of health inequalities caused by social, environmental, structural, or political factors. So some of these examples can be exemplified by poverty, structural violence, and stigma. And the interaction of these different conditions exacerbates the disease burden even more so. So when they stand alone, it may not be as impactful, but when you combine all of these conditions together, it's really, really, it sheds a light. And people keep saying that COVID-19 has basically unearthed a lot of the things that we already knew was happening, but now it's blatant and it's glaring and it's in our faces, and we need to do something about it. Otherwise, we're complicit if we do nothing, right? So one of the things that I want to talk about is just, what does it look like within the past almost year, right? So last year, if we're talking about from a particular cultural group, so I'm talking about Black Americans here, there was an experience of racial trauma. So race-based traumatic stress, these are just symptoms that kind of mimic post-traumatic stress disorder, but the cause of the trauma is from racism. So that would be an example of race-based traumatic stress. And then there are people who do have some disease burden, like people who already had anxiety or depression that could be caused by racial trauma, or maybe not, or experiencing some other mental health illnesses, or have some medical conditions, like people who may have diabetes or have had hypertension. So that would be another example. And then, again, just talking about what happened last summer, and what's always been a continuous issue for the Black community, for example, is systematic oppression. And this is just not, again, unique to the Black community. There's also other marginalized populations, immigrant families who's also experiencing systematic oppression from those Latinx or Latino cultures. And then we have COVID-19. So COVID-19, when you have all of these, and the factors related to COVID-19, such as someone contracting the illness, which can also cause some type of disease burden, or even if they didn't contract anything, but losing a loved one or having a loved one still suffering from the sustained long-term effects of COVID-19. So all of these factors, when you mix them all together, this is where, when they're combined together versus individually alone, there would be this is what we would call the syndemic. So this is, again, the mutually reinforcing interaction of diseases and social conditions. So again, when we think about, African Americans or, subjugated groups in this country for many, many years, such as Native Americans. There's so many historical and present day factors that have created these endemic conditions for many marginalized groups. In particular, with Black Americans, we already know that there has been, we experienced the lethal force of COVID-19. And we know that Black people typically have those essential worker positions and have been more exposed and have experienced more mortality compared to any other groups, white counterparts in particular, as a result of COVID-19. So then that already has happened. But then again, talking about historically, there's been slavery as an appendage that has been passed down for hundreds of years, but redlining, gerrymandering, lack of Medicaid expansion, employment discrimination, healthcare, provider bias. So all of these factors that have been around, these structural inequities that have been present for so many, many years can exacerbate one's disease burden. So again, if you think about it separately, there's already issues with experiencing either structural inequities or health concerns, but when you combine it together, that again, the social conditions can exacerbate one's presentation. So I'm going to stop sharing my slides. So when we talk about, again, with our youth and families, COVID-19 has been incredibly impactful for those for Black Americans in particular. And I think this is true for other families too, that, COVID-19, many families kind of live by some of the fears, because these fears are legitimate fears, again, because so many people have experienced loss, and so many people have experienced so many illnesses related to COVID-19 that the threat of something bad happening is very real, but it definitely takes a toll on mental health. And there's a lot of negative health outcomes that stems from that.
Thank you so much, Dr. Dinizulu. I want to remind our audience to please use the Q&A function to put in questions, because we want to make this evening as interactive as possible. We are minimizing the number of slides that we're going to be showing, but we want to make sure that you have the opportunity to provide questions and comments to our discussants this evening. Dr. Olopade, could you talk a little bit about the issues around public health and COVID-19, and also some of the things that you have seen on the global stage?
Yeah, thank you. Very early in this pandemic, a lot of people were advised to stay at home, to socially distance, and you can imagine for people whose job entails going to work every day to provide for their family and living in small, tight quarters, that was not going to be possible. So as a result, people who felt obligated to go out and make money to support their families got infected. Those who needed to do multiple jobs had no choice, unknowingly were just transferring the infection from one place to the other. And if you look at it from the public health perspective, the misinformation that this virus was a hoax, where a section of the population decided they were not going to use masks, that explains why we are where we are today, with more than 500,000 Americans dead, when we have the best public health people at the CDC all over the world. One particular interesting perception that I want to get across that will buttress Dr. Dinizulu's perspective is highlighted in this single slide that I'm going to show you, which essentially demonstrates that when you have inequity within a country, that inequity actually drives, can you see my slide that I'm sharing?
Mm-hmm.
Yes, give me 1 second. it drives, let me show it here. Okay, I'm sorry, this thing is not showing up. Okay. This is just a slide that shows, um, okay, sorry. Okay,
Very
this is
good.
this, can you say?
Yes, thank you.
Yeah, this is a slide here that shows the relationship between income inequity and we as a factor that drives mental illness and physical illnesses. What I want to show you here is you see this on this vertical axis. This is the percentage of people with mental illness. It could be any other health outcome. And you look at income inequality. From high income inequality to low income inequality. When you look at the top here, this is the United States of America, where we have one of the highest income inequality in the Western world. And you can see that it directly relates to the very high percentage of mental illness. Also, the health of a population can easily be determined by the inequity that exists in the system. You can look at Japan, Belgium, and other countries where income inequality is much, much smaller. You can see that there is a relatively fewer incidence of mental illness. It's also important to know that even among the wealthy folks in the United States, where there is high income inequality, life expectancy is also generally lower that when you compare to places like Japan or Belgium and other places where income inequality is less. So whether we like it or not, income inequality affects both the rich and the poor. And the health of any nation is pretty much determined by how much disparity that we have in the system. When you look at this from the global perspective, I just want to remind or jog people's memory about what happened maybe about 4 or 5 years ago when Ebola came to this country. People in their wildest dream didn't think we could ever get exposed to that kind of infection. But we live in a more globalized world where just a 12-hour plane ride, you can get to America from Asia, from Africa. So we're all involved in this. We're linked. Hence, you can see how easily the pandemic spread everywhere. If the impact on the pandemic in America is partly due to inefficiencies in our system, when you look at places like Africa, where they don't even have they have just a fraction of the resources that we have. Public health strategy was what they needed to use that accounted for the low initial mortality, even though there is underreporting of this mortality. But they've pretty much done better than we have in the United States. But the second wave is a little more serious, and people are facing the challenge of whether they need to stay indoors, starved from not having anything to eat, or go out and get the COVID infection, which is not going to kill them anyway. And one other thing that is unspoken most of the time is that innovation in Africa, in a lot of the African countries, has actually helped them to type the kind of COVID variety that they have. They've also developed diagnostic kits on their own so that they could determine who is infected or not, because it will probably take a longer period of time for vaccines and things like that to get to them. But thanks to the consortium between the World Health Organization, the Gates Foundation, and a new organization that's called COVAX, where they've actually committed to send about 1 billion doses of the COVID vaccine to low-income country settings. And I'm really very, very happy that the first delivery of that vaccine was sent to Ghana today. Because if we don't take care of others who are in low-income country settings, we're just going to be as vulnerable because the ease of travel puts all of us at risk. So the morale of this is we're all intimately related, and caring about those that are under privileged, both in our country here and globally, is a moral thing, is a moral imperative for all of us.
Thank you, Dr. Olopade. You know, both your comments as well as Dr. Dinizulu's comments around mental health and beliefs, and particularly in framing this around the vaccine, I think raises a question for me. And it's something that we talked a bit about in preparation for this seminar series. And that is, how do one's religious beliefs, how do one's experiences with the healthcare delivery system in the past impact the uptake of viruses, of the vaccine, and specifically some of the issues that are coming up around vaccine hesitancy? Dr. Dinizulu, I'll turn that question to you first and then come back to Dr. Olopade.
Yeah, sure. So, you know, this country has a historical legacy of, again, with marginalized groups, particularly Black and Brown communities, including Native Americans. So BIPOC, Black, Indigenous, people of color, have been disproportionately experiencing unequal treatment in modern day healthcare systems, and even for hundreds of years. So this level of mistrust around the vaccines is justified, and the burden is really on the medical and public health campaigns to really promote the effectiveness and usefulness, and to help Black and Brown communities to feel more comfortable and establish a sense of trust in this vaccine. So the beliefs are, stemming from, the Tuskegee, experiment. We know this to be one of the anchors to help exemplify why there's a huge distrust or mistrust within the Black community, for example. And this is, again, the syphilis study, where for about 40 years, from 1932 until about 19 something, and a few years before I was born, that Black men in particular were not given the intervention. And so a lot of the mistrust stems from the Black community understanding that, and definitely citing that as one of the reasons. Henrietta Lacks, if you ever read the book, The Immortal Life of Henrietta Lacks, but she had cervical cancer, and her cells were used by Johns Hopkins institution. Her cells are on the International Space Station today. Her cells have been able to revolutionize medicine, and have been able to find more vaccines to be developed based on her cells, and treatments and so forth, and therapeutics. And her family never received a dime, or never even knew that they were using her cells without her consent. And then we've had Black people have passed down, and BIPOC communities have passed down stories of, sterilization of women. Just not too long ago, in 2010, I think it was in North Carolina, I can't remember what state, but women in prisons were forced to be sterilized. And that's nothing new, trying to control the Black and Brown bodies for many, many decades, to either experiment on or control population. That's nothing new. So I think, the burden is on public health officials to really try to teach and educate and support communities as much as possible. However, you're talking about 400 years of this being instilled. So it's not going to happen overnight, but it is promising that, the rates of accepting the likelihood of someone getting vaccine among the Black communities and Latinx communities is steadily rising. The last time I read something about this was in December. It was about 43%. Now it's about 53% as of the beginning of this month. I'm kind of tracking, because I am promoting and sharing this information with the patients that I'm working with. Like, I feel like that's part of my role. And I myself have received the vaccine, and know, some of the misbeliefs about the vaccine in the Black community, for example, is that, well, in the very early on, because we have melanin, we have darker skin, that, oh, we're immune to the vaccine, and that's not necessarily true. So there's always been some misinformation going around, and that people, you know, are feeding information to each other, and not sharing the right information to encourage vaccinations. And, you know, with Black people in particular, for example, and I think this is true of everybody, the whole population, because, you know, whether if you're Black or not, I think vaccines worldwide, sometimes there's misinformation about it, and people still have distrust about vaccines and wondering if it's going to damage or control their body. But particularly for Black people, one of the things that, you know, Black people have been concerned about, or have been telling other people about the vaccine when they're asked if you're going to get the vaccine. One answer is, you know, like, no, I'm not going to do it. And then the other one is like, I'm going to wait and see. Let me just wait and see what's going to happen 6 months from now, 7 months from now. And the reason why I'm talking so much about the Black community is because in this country, I know 13% of this country is considered of Black Americans, but we cannot achieve herd immunity without Black people, without Latinx people. So I think it's really important, because that's not what they're talking about. Like, they keep talking about herd immunity, but one epidemiologist that I agree with, and I can't remember her name, I'm sorry, this is failing me. I can't remember her name, but I've looked in some of the work that she was doing, and you know, her standpoint is stating that, you know, herd immunity cannot be achieved without Black people and Latinx people as being a part of this. So I think, you know, it makes sense to move forward carefully with vaccines in general. I think you know, meaning helping people feel comfortable if they have questions about it, that we pace ourselves and make time and space and not be judgmental and quick to dismiss. And because Black people haven't been believed before. And so, you know, we need to not, you know, take other opportunities. We need to take opportunities to allow for people who have concerns about the vaccine and help them feel comfortable. So that includes people like me, like Dorian, Shola, everybody who's on this panel, everybody who's listening. I think it's really important to spread positive information about the vaccine. There was one other point I wanted to make, but it'll come back to me hopefully later. But thank you for allowing me to answer that question.
Thank you.
Yeah.
Dr. Olopade, when we were preparing for this seminar series, one of the things that you shared with us had to do with vaccine hesitancy, and in particular, religious viewpoints. I was wondering if you could share some of your perspectives on that with our listeners this evening.
Yeah, thank you. If you look at the challenges that people of color have gone through or go through daily, you will understand why going to church on Sunday is so important. Without church on Sunday, I don't think we'll have enough mental homes to keep people who are totally stressed. So as a result of the redeeming or empowering nature of church, being in communion, people pay attention to what their pastors tell them. Both here and probably even more important in Africa, for example. And it's not unusual that when people suffer serious illness, not even specifically this COVID infection, what they're going to go to do first is probably go to their pastor. And depending on how open-minded that pastor is with respect to accepting what is called Western medicine, they may just elect to just go and pray, or decide that you know, you reject that ailment, that's not your portion. You're not going to accept that it is true. So that level of denial sometimes accounts for late presentation. It accounts for worse outcome for some of the diseases that people may have when you look and compare it to people of color. Going back specifically to COVID, the biggest challenge that I know that in Africa, I don't know whether that plays out here, but I'll be surprised that it didn't play out here in the United States the same way. Some of the pastors really challenge the people to have, to trust their faith and not be fearful. Equating the need to be doing social distancing, equating wearing masks to really being a very weak faith. And in the context of a pandemic where, one of the safest and best protection that we could look up to early in this epidemic was the wearing of masks. You can see the implications of that on people who chose not to wear masks just because of religious fanaticism, or people challenging their faith by doing what is appropriate. And we also know that when it came to maintaining social distancing, there were so many of these big mega churches that went to court to challenge what seems to be reasonable public health strategies to minimize the spread of this pandemic. So religion is very, very good, but it serves potentially as a two-edged sword. It helps to put people in community, so that you don't feel isolated or depressed with just being isolated at home. So when you take that away from people, it poses additional challenges. But preying on people's religiosity by letting them, making them feel that they have weak faith is very disingenuous, and probably contributed to some of the challenges that we've seen with the spread of this pandemic. Yes, as as a bioethicist, yes, I also teach responsible conduct of research. So it's important to let people who are on this call and people of color who they're quite right. All of the injustices, all of the atrocities, all of the exploitations in research in the past. It's important for everyone to understand that we all need to participate in research, because if research, the way it was done previously, was conducted in men, feeling with the understanding that whatever happened to men must be applicable to women. But when we started studying women, we realized, oh my God, women are actually different from men. Similarly, if they do studies that is done only in the suburbs without inclusion of people of color, there is no guarantee that that outcome from that particular study is going to be relevant to people of color. So that's why it's important for all of us to participate, all peoples, children, rich, poor, tall, all of us must participate so that we can spread out the risk and enjoy the benefit. Because the reality is we're in the process of what we call precision medicine, where when you come to see us maybe in another 5-10 years, we're going to look at your genetic profile and use that to determine what to treat you. So the earlier we find a way to be more ethical when we do some of these studies, without thinking for the first time when you need to do some of these vaccine studies. I know that some of the French folks wanted to go to South Africa first to go and experiment on, Africans before testing whether it's safe before coming here. So I'm hoping that we can encourage all people of color and everybody to take this vaccine, because that's the only way it's going to be safe for all of us to go back to what life was like before this pandemic that's lasted more than a year.
Very important point in terms of inclusion, and inclusion across the board in terms of diversity and testing, clinical trials, and why it's so important for communities. I had a question in the chat around the pandemic getting worse. And the question is, do you anticipate the pandemic will get worse in the Black community for fear of being vaccinated, or possibly barriers in terms of accessing appointments? And so Dr. Dunazulu, I'll ask you to take on the issue of the fear question. And then Dr. Olopade, I will turn to you and ask you to talk a little bit about the issue of access. So Dr. Dinizulu, fear and worsening pandemic.
Yeah, so so this is why I was kind of saying earlier too with, I remembered the woman's name, the epidemiologist. She's the dean at public health at Michigan State University. So her name is Deborah Fur Holden, who talked about the importance of Black people getting the vaccine, and especially in those communities that have more acceptable rates, where they don't have like a high rates of those Black communities have high rates of COVID-19, excuse me. And so again, Black people tend to experience structural inequalities that prevent, adequate health care. And they continue to be essential frontline workers, essential workers. And so that won't change because the structural inequities are still in place. I think when COVID is all said and done, these structural inequalities will still be in place unless we really act on it. So I think that fear can definitely be heightened when there's not much of the needle still moving towards people getting vaccinated. And so we really, really have to work hard to help Black communities to understand that this vaccine is safe. And that, hopefully other Black professionals, Black people who are in the community, professionals meaning like medical care professionals, other professionals in these different spaces, families, churches, pastors, the Black churches are historically have been rooted in promoting a lot of things, social justice, and they have been promoting wellness programs. So that's something that's been historic. Politics as well. And so hopefully, again, figuring out ways of how we can make this reach of working in our local barbershops. The University of Chicago, I don't know how many barbershops we know in the South Side of Chicago, but that would be one way, for example, to get the word out, and hearing from a barber versus from a doctor might be more impactful. So I think the fear can grow if we don't act fast, and if we don't act effectively, and if we don't take a partnership and spreading the campaign and spreading the information about the safety around the vaccine, because the world will continue to move on without groups of people who don't want to get vaccinated. The world will continue to go on because there are people who want to get it, and they will get it. They'll find ways to get it. But we need to remember that the people who are most vulnerable are the ones who are the backbones of this country. And we need to really, really be effective in our campaigns reaching these communities.
Thank you, Dr. Dinizulu. And Dr. Olopade, the second part of that question was about the issue of lack of access to the vaccine for communities of color in the Chicago area. Do you think that that's going to contribute to a possible worsening of the pandemic?
One of the good things that's happening, in the new administration is that at least more and more people are getting vaccinated. And until a critical mass of us get vaccinated and we get to what we've been describing as herd immunity, everybody is still going to be at risk of getting this virus infection. And especially if you look at people with, when we look at social determinants of health, meaning the conditions in the environment where we live, where people learn, work, and play, affects vulnerability to still catch this infection, especially if you have the younger kids going out, wanting to live their life and taking it back to grandma. So access to vaccination is going to be very, very crucial. And in that context, I'm actually very, very proud of what the University of Chicago has done during this pandemic, because very early in the process, people used to think that just being Black or being Latino meant that you were more likely to die from this COVID infection. I know the experience from the University of Chicago is that if you were fortunate to be able to get your treatment at the University of Chicago, there was actually no significant difference between Black, people of color, white, or it didn't matter. So it's pretty much the outcome, bad outcome, it's pretty much determined by the risks that you bring: obesity, hypertension, diabetes. So that said, I am hoping that I was excited today to hear that from the governor that we're going to get almost double the number of vaccine that's going to be that's been allotted to the state of Illinois. And strategically, effort to vaccinate the most vulnerable groups is ongoing. If it were left to me, I would actually try to vaccinate a lot of the younger mobile people earlier, because all of the older folks, they recognize it's dangerous to them. Everybody is staying at home. They're not going to spread anything. It's the younger people who are still going to parties, trying to maintain a social life. I mean, that's why they are young. Those are the people taking this infection back to grandma and to their parents. So at least now that we've got into people that are 65 or that age, it would be really reasonable to start capturing that vulnerable young population that are spreading this infection all over the place. Whether there is enough vaccine to make that happen, and how we get all the scared people at home to get vaccinated, that's going to be the challenge of the new administration's desire to make sure that everybody has enough vaccine by the end of March.
You know, Dr. Olopade, your point about young people and their mobility and wanting to go out and socialize is a very nice segue to another question that we have in the chat box. And I'm going to turn to you, Dr. Dinizulu, for this. And it has to do with the mental health of high school students and their worries and concerns about their future. One of the things that we have seen in terms of mental health concerns is that it actually seems to be more of the young people, the adolescents, and also the young adults who seem to be struggling the most in terms of mental health outcomes around this. And I'm wondering what can be done in order to help to support them.
Yeah, thank you for asking that question. This is really tough. You know, Dr. Olopade already mentioned that, you know, a lot of the families have multi-generations. And so the concern of letting your child go to school, even if you might have an in-person option, and that's becoming more and more reality. As CPS, Chicago Public Schools are coming back to school, and a lot of the private schools here have those options. And then coming back to an elder in the community or within their family and bringing that home. So a lot of families are trying to protect their elders within their household, their very, very best, of not letting the teens go out and do anything at all. And then there's another set of families where, you know, they may not have any elders in the community, but there's real anxiety related to COVID-19. You know, we know that most people who contracted do not die, right? So we know this. But the question with COVID is that it could be so random for some people that one day you're fine and the next day is like, wait, what happened, right? So people kind of tend to focus on, you know, the media tends to focus on a lot of the extreme cases. And I know there's a lot of extreme cases, so I don't want to minimize the impact of COVID-19 because it's very, very real. I think we all can think of someone who's been impacted in a really, really horrible, traumatic way. And so families kind of, you know, stick with that and ruminate with that. And it's just hard to let go of that fear. And it's a reasonable fear. However, I think it's important to understand, like, how do we adapt to adversity? How do we take chances? You know, humans, we have been doing this for quite some time. You know, it's the spirit of the human spirit is just limitless, right? There's so many potentials that we can reach. And so how do we be creative and allowing your youth who's in your household or young adults to safely do something together? Because at this point, you know, I'm starting to see definitely an uptick of, you know, suicide attempts and ideations, people developing more anxiety and depression, rising rates of child abuse, domestic violence, because now people are starting disclosing. At the beginning of the pandemic, I didn't really hear too much. And I'm like, what's going on? Because this is not what we're anticipating. But now, literally, I get a call every week for services because my kid is depressed because of the pandemic, or anxious, or there's, abuse. So I think the mental health costs, which could be long-standing than being sick for COVID for 2 weeks and not potentially dying from it. I feel like the mental health is that, the scales are starting to tip a little bit, where now I'm trying to negotiate with families. Like, if you have a very severe depressed kid, I'm prescribing that the kid needs to go out and do something, something safely, figure it out as a family. We can talk through some steps. I don't want to prescribe anything that is blanket because I think it is unique to every family and the resources that are available. Like, I can tell some families will buy an air filter, and maybe you can have 2 people in the home, separated socially or physically distant, having the mask on all the time, staying in one space that's big enough, to families where they don't have that resource. And so I think of different strategies. We think of something together where they can do something that's outdoor. And I know Chicago doesn't lend itself to have such of the wonderful weather, like in Florida and other warm places, but today was a great day to be outside. And hopefully people can take the best advantage of what's to come with the warmer weather coming, the spring season coming up. But I think the biggest thing is to try to live by facts and not by fear. I think if you have access to people that you trust, that you can talk through and work through and problem solve, like, what are some ways that I could, boost the mental health boost wellness within, my teen or my child. I think you have to have those conversations, because the conversations that I'm hearing a lot from families, like, no, you can't do this because of COVID. No, you can't do that because of COVID. Everything is no, and it's not so much of, okay, let's try to figure out and be creative of what we can do in the different spaces and with the resources that we have. So I think I'm encouraging all the families that I'm working with, let's just think creatively. Let's be safe. There's always still a risk. That's in everything we do, right? But we can't live by fear. Let's just try to live by facts. We know that masks are extremely effective, very, very effective. There's been studies to show there's 2 hair cuttery stylists had seen about 100 clients within a week. They both had COVID-19, and none of the clients had COVID. And they did a study to follow these people, and nobody got COVID because everybody was masked and they followed the protocols. And they weren't able to keep social distance, apparently, because you're getting services for at least 30 minutes. But it goes to show that, masks can still be effective, and that people just need to, hold tight, wear the mask when you're together, and try to remain that distance. And I think there's a lot of good things that can come out of that. So that's the advice that I could give. But watch families, their mental health, ask the questions. If you're concerned about suicide, for elders or for young people, ask the question, have you had these thoughts? Because people think that if you don't ask the question, you're not going to open up a can of worms. And so, or you think if you ask the question, you're going to open up a can of worms and cause someone to think about suicide. Well, actually, that's the opposite. The research does not support that. Like, asking about it and showing concern about it is really, really important. And seeking services for help, for mental health services, is really important. Just so you know, it's going to be hard to find a provider. I'm not saying don't look for someone, but if you find that someone in your family is in need of mental health services, spiritual connections to your faith-based organizations might be a good source to help, but also just mental health providers, where we're full, because we're getting a lot of kids, a lot of adults are coming in. They really, really are. And it's almost like the ER where we work at Comer. It's been a lot of mental health crises that are coming through the ER more than anything. So as of late. So I think it's, again, really important to ask questions about mental health, problem solve, be creative, try to live by facts and not by fear, and wear your mask. When you're trying to figure out things to do with people, wear your mask. And I think those things can be achieved, where you can achieve social distance and still wear your mask and be safe.
It also sounds as if it's an evolving conversation, because as the circumstances of the pandemic change, the response to what we can do in order to do things together and yet be physically distanced, which I think is a point that I've heard Dr. Olopade make in the past, is that there's a difference between being socially distanced versus being physically distanced in terms of the pandemic. I'm going to turn to Dr. Olopati with this next question. And this question has to do with the increase in race-based violence against Asian immigrants worldwide during the pandemic. Is this something that could be addressed through public health messaging?
Oh, yes. Anytime people make stupid decisions like that, that's one of the possible roles for public health intervention. I think it's very, very important for our leaders to be able to take leadership in that role and let people know it's completely unacceptable to ostracize any particular group in our communities. Because but it's not too shocking because when you say this is a China virus, I mean pandemics do happen and it's a reflection of our interconnectedness. So to pick on a particular group of people is very, very unfortunate. But I think from the public health perspective, sharing facts, getting leaders to come out openly and denounce such unkind actions is going to be very, very important. And one comment that I actually had in response to the last talk with respect to education of young people is what this pandemic has done. It's actually unmasked a lot of the inequity that's in the system in terms of the digital divide. If you look at young people who live in settings where they can't socially distance and they don't have access to internet to be able to continue their work. Nothing could be more frustrating or disappointing to a young person who is unable to continue with schools, who's unable to be in a setting where they can be with their friends. So what I'm hoping and praying for is that the collateral benefit from this pandemic will be an effort to make sure that we can work on ensuring that there is no digital divide, that people in all places have access to broadband internet so that all of our kids can benefit from being able to do remote learning. And life's never going to be the same anymore because even from the hospital perspective, we are beginning to blend telemedicine with face-to-face interaction so that people who are still scared and don't want to come to the hospital, there's a way we can still see them and take care of them. And when this is all over, it's actually not a bad thing so that people don't have to come to the hospital and drive so many times looking for parking. So being able to blend and use technology would be a good way to take advantage of this pandemic when it's over.
I wanted to say something. Yeah, I want to add on to what Shola was saying too. I think the digital divide is very real. I think a lot of the issues that I've had with doing a lot of telemedicine is just the broadband connectivity. So I think that has been an issue to use for devices like a laptop or a tablet. But I work with young people. But our teams, they seem to have, working from the phone is not ideal for like remote learning. So that's not what I'm suggesting. But I also want to look at, we still have connection to our teens with the phone devices. Mm-hmm. And so we need to really think creatively about how can we reach them through, to help counter some of the digital divide and to help counter like how to promote wellness and health through those devices that they do have access to. And it's like their only thing, for some families who don't allow their kids to do anything but stay home, that's their only main source of connecting to the outer world for the most part, or connecting with their friends, some of whom are still getting together and they're missing out, right? So I just want to highlight too that there is an upside that they have these, they have the phones. There's very few families that I work with where I'm working with an elder. So there's multi-generations and the elder is the caregiver and the flip phone is what they had. There was not even a smartphone. So, but thankfully, I have seen lots of families do have cell phones or smartphones. However, the broadband is the issue, but also we need to capitalize on being able to use what they do have as much as possible, in addition to trying to close that gap of the digital divide.
Thank you for that comment. I'm going to step outside of my role as moderator for just a moment because I am a primary care doctor and my patients have been impacted by the pandemic, and in particular, the patients that I care for on the south side of Chicago who are having difficulty with broadband and the digital divide. One person put into the chat box is this impacting people's ability to receive care? And we have done as much as we can in terms of reaching out to people, calling them on the phone and trying to get them to come in. But particularly early on in the pandemic, people were very concerned about coming in for care because they were concerned that the hospital was not a safe place to come for care. And so studies have been done in terms of people coming in with delays for both heart attacks, strokes, other serious conditions, delays in terms of getting standard cancer screening. All of these things are coming into play. At least we can provide some relief in terms of some services through what's called telehealth or telemedicine, which is defined in the chat box. But again, this is something that particularly rural communities and many communities that are low income continues to be a struggle. And now I'll put back my my hat on as a moderator again. Thank you for allowing me to take a little bit of time to talk about that. I want to spend a few minutes this evening before we wrap up to talk about the issue of self-care, Dr. Dinizulu, because I think that one of the questions that's come up in the chat is, are we going to be left with a pandemic of major mental health issues once we start to get to some sense of normalcy? And I think a little bit about this from an experience that I had this summer in attending a funeral for one of my patients who passed away. And going to the funeral home and watching people go into the funeral home in groups of 10 in terms of being able to view the body, but not having the normal ceremonies of grief and loss and the way that people gather together, and how that the collective impact of grief and loss is going to affect our mental health going forward. And so what kinds of things can we do in order to try to take care of ourselves during this time, knowing that these are unusual times?
Yeah, so that's a great question. Unusual times for sure. And the longevity of this unusual time is very taxing on everyone's mental health. Everybody has been touched in some way. Family traditions or just traditions in general have to be reimagined. Some had to be canceled. The isolation or the reduced capacity to see one another, families struggling with juggling different schedules, trying to do remote learning, being homeschool teacher and working at the same time, dealing with kids at all different developmental levels. So all of this, again, it's just so important to think about this and the self-care and it's just, I'll get to that in a second, but the long-term impact of this pandemic, we don't know for sure. We can talk about Hurricane Katrina and how that wasn't as long, but it was very devastating. Some people have been incredibly resilient. The shared stories of that kind of collective trauma, a natural disaster in that way, was a collective trauma, and they found ways to recover and to be resilient. And they had a sense of hope. And I think for us struggling with this pandemic, even though we're not like Hurricane Katrina, this is more of a not as an impactful couple of days or even couple of months. We're going to be rebuilding for some time. And I don't want people to be stuck in this mindset of it's just doom and gloom. We have too much history, thousands of years of being humans. And we have seen lots of communities, groups of people, the human race have overcome a lot of adversity. So I'm coming from a very strength-based approach. We can easily get lost and wallow in sorrow and in grief. And not to say we can make space and room to experience those phenomenon or emotions. It makes sense. We're normal, we're human. But to be fixated on it for quite some time becomes more harmful than good. So there's so many things that I try to share with families and with young adults. And when I say families, I'm talking about families that I work with from multiple generations. So we have an elder in the home to an infant, that could be ranged. So I'm speaking broadly, but I think just, find out what is the strength that's within your community and building a sense of community. We're not alone. We see that hashtag that we're all in this together. Well, we're not alone. And sometimes I like the hashtag and sometimes I don't. I think it's just depending on, we're not really all in this together because some have worse outcomes than others and some are not getting the resources. So I think what I mean by that, when I would like to reference and how I would like to define that is all in this together within your community. Find your sense of community of social support. There's parts of our brains that support us being social, because we know that when we live in social communities, we tend to thrive better. So going back to the basics of being able to connect with other people and having social support is so incredibly helpful. If you're isolated and living alone, or if you know someone who's isolated living alone, it's our duty, it's our job to try to connect with those people that we know who need that support, especially our elders, especially our senior citizens who might be living in nursing homes, or those who might be living independently without any family around. They're very, very much at risk, and we need to reach out to them and find ways to socially connect with them. It could be virtual, again, it could be in person, distant, again, wearing masks. If I could see patients, Dr. Miller has seen patients, Dr. Olopade, I'm sure, has seen patients in person. We're wearing masks, probably I spend at least an hour in my room with patients. I don't have 30-minute visits, but there's safe ways to do this and for us to socially be together as long as we follow the guidelines. I think the other thing to keep in mind is to have hope. That is a strong predictor of a lot of great outcomes. It can fight against anxiety, can fight against depression, but having hope is another way to counter some of the negative effects of COVID-19, the mental health, that's the negative mental health effects that stems from COVID-19. Having compassion for the situation, accepting things that we necessarily cannot change. But the compassion piece, just going back to that for a second, is just, some things may not always work out the way we want them to be. Sometimes we can be hard on ourselves. Sometimes we feel like we may not be doing a good enough job. And I think it's all of this is okay. We're operating in unforeseen circumstances from back then. And now we're working in circumstances that have not been seen like this before in history. It just looks a little different. But again, adversity is not new to humans. We can overcome this. We can work through this. But I think the social network is one of the strongest things that can bond all of us together. And we talk about this all the time, that, we can be together, but we have to physically distance, not socially distance. That's just a reframing of how we can think about being together. And again, just going back to practicing self-care, going for walks when you can, if you're physically able, if you're able-bodied. And again, keeping this in mind, this is not going to be prescribed for every single person because everybody's different. But being able to be mindful of your situation and again, have compassion for the situation. It doesn't mean you condone or forgive. It just means this is where I'm at and what are some of the things that I can do to help me cope or to help me problem solve and work through this. Exercising, eating right, getting good sleep, again, staying socially connected, even if it's through virtual means, seeing your primary care physicians like Dr. Miller, keeping those doctor appointments are so important, even if you are afraid. And if we keep saying that it's safe, then trust us, because we're at risk too. Healthcare providers can still be at risk. But if we're saying that it's safe, try, talk it through, problem solve. Sometimes people just need to have a script in their head and talk through different ways to help them internalize the thing that they're struggling with. So internalize the thing that we're trying to teach about safety, and then internalize that so that they can then act on those thoughts and behaviors to then move forward. So basically to be motivated. And sometimes people cannot internalize those messages of safety and protocols that are in place to help you stay safe. So I think, again, keeping up with your doctor's appointments and visits of that nature is really, really important. And I think just if you're tonight, I just give you all a task: call someone, get in touch with someone this evening before you go to bed. Just get in touch with someone and just check on them. Just check on them. And if you need to be checked on, and you feel like no one might call you, then you go ahead and call somebody, connect with somebody this evening. I think it's really, really important just to get the ball rolling, leave the stuff in the past and just worry about the present moment of, I just need to talk to somebody, I just need to see you. So try to make plans around, again, staying socially connected, but in a very safe way.
Thank you, Dr. Dunazulu. Dr. Olopade, we've got a couple of questions that have come up, I think really spurred by your comments around getting young people vaccinated. And the question of both vaccines in children, but also advancing the idea of vaccinating young adults, or is it too late to do so? And I think that the question in the comment challenges the current guidelines from the federal government regarding vaccinating older populations first. So any thoughts about that?
Yeah, I can understand why, the federal government is focusing on older folks, because if you look at the beginning, most of the people who succumbed to this virus were people in nursing homes. And having lost so many of our elderly people, it makes a lot of sense to try and focus on how to protect that vulnerable population. But as I mentioned earlier, most of the elderly folks know now to limit what they do. So they're already at home. They're not going to get COVID at home if they're fortunate to live in a place where they can actually self-isolate. The nuclear bomb in this pandemic, until we get to herd immunity, are the young people. And most of us know that they are the people carrying this around. They don't even have to be symptomatic. So until we get to herd immunity, where a lot of people have become vaccinated, I think it makes perfect sense to try and vaccinate some of these younger people who are, who get it and are not asymptomatic. When it comes to younger children, I don't know. I don't think I have a particular opinion on that, an informed opinion when you get to the, younger children, because at least the data that we have is that they just bounce around and do what they have to do. So I think the strategy to try and make education come back by focusing on vaccinating teachers is a very, very good policy, because if the teachers are vaccinated, they're more vulnerable than these children, then everybody will be safer. The children will be able to go back to school earlier in a setting where the teachers feel much more comfortable doing their work without fearing that they're going to catch COVID from these young people who are asymptomatic and take it home to their own children. So I think it's a good policy, but people are reacting to the initial high mortality that we saw in the elderly population, and I can't fault that.
The other issue, and just to step out of my role as moderator for just a moment, is that the current vaccines that are available were only tested down to the age of 16. There are current studies underway in order to do testing in a much younger population to make sure that the vaccines are safe and effective. And so once we have that data, which is expected sometime in the late spring, we'll have opportunities to start providing vaccinations for those younger age groups as those public health guidelines evolve. I think that at this point, I would like to bring in Dean Osborne in order to give her the opportunity to ask any questions of our guest today. Dean Osborne?
Now, do you hear me?
Yes.
Thank you. This has been a wonderful conversation and really enlightening and eye-opening. I have many questions, but I guess, Sonia, I want to go back to the point about that you started talking about barbers and about different creative ways to connect with communities. And do you have, are such possibilities being pursued? How are communications being managed and promoted in a way that is meaningful and might bring people in to be vaccinated or understand better the disease?
Yeah, so the barbershop studies have been around for quite some time. So it's not unique to COVID. They've been, tapping in, a lot of Black researchers have been tapping into working with barbers to promote like mental health or wellness of that nature. So I think I'm not quite sure what's happening in the Chicago scene. That I'm not sure about. So I kind of put out a feeler, and anybody's listening who might know that work, please put something in the question and answer or connect with me. But I think that I'm not aware of University of Chicago with our outreach in the communities through the Urban Health Initiative. If there are close ties with barbershops. Barbershops are very historic in Chicago, a lot of history, a lot of culture, a lot of new innovations have come out of those spaces. And it would be great for us to have a relationship with barbers, and we can read previous studies that have been that talked about awareness related to just like health and well-being. Diabetes education, I think, was one study. Another one was about sex. I think another one, I can't remember all the studies that have been done, but there's a number of studies that looked at barbershops being effective in promoting health and wellness.
Shola, similarly, when you think about Nigeria and the pandemic, not similarly necessarily, but when you think about Nigeria and the pandemic, what do you think that has been sort of learned, or policies that have been taken up that in a sense might have enduring effects beyond the pandemic, or practices? I mean, it seems to me that one of the lessons coming out of West Africa is the pandemic has not taken root in the way that people feared at the outset. And you have talked about the second wave taking a larger toll, and there's mitigating factors in all this. But it also seems that there can be a great deal of pride to the fact that it's been managed quite well, and governments like in Senegal as well have really stepped up. So I wonder what you think. What are the lessons for the longer term in this experience?
In countries in Africa, the public health intervention is what they have. They don't have access to all of this remdesivir, the antibodies that we have here. And fortunately, I remember about 5-6 years ago when the Ebola pandemic struck, when a diplomat went from, I think it was Senegal or, to Liberia, introduced Ebola to Nigeria. It happened at a time when Nigeria was preparing to do vaccination to end polio. Okay, so they had developed a public health intervention to do contact tracing, to do all of that. And then Ebola showed up. And people, if you look at Nigeria, Nigeria has a population of over 200 million people. And Lagos, where Ebola was introduced, has a population of about 19 million people. You can imagine how devastating it would be for Ebola to perpetuate the communities in Lagos. What they did was they just threw money at it in terms of contact tracing, public service announcement, debunking fake news on the internet, telling people if you have symptoms that suggest you have Ebola, don't come to the hospital. Just tell us where you are. And they went that, and in about 93 days, they eliminated Ebola in Nigeria. So public health interventions work. And that's why, as a physician, and a public health person, I'm a health policy person, it's very, very frustrating that we lost this many lives because public health interventions, getting good messages out there, prevents a lot of the mortality that we've gone through. So again, the lessons learned is from the Nigerian experiences. Yes, the public health intervention helped. The lockdown helped, but when you have so much poverty and people had to make a conscious decision between staying home, not having access to food, and having COVID, where if you got COVID, you got taken to a center where you'll be fed 3 times a week. You stay there for 2 weeks until you got negative. It didn't kill you. So people who are making such calculation in terms of risk benefit, yeah, especially if you didn't have all of these adverse underlying risk factors. So the bottom line is public health interventions work. Innovations from all the investment in global health helped because if you look at even from Gambia and Senegal, they developed their own test kits. In Nigeria, they were able to type they can do able to do PCR to know the type of COVID they have. So the investment in global health has helped to provide that level of independence. Otherwise, it would take a millennia before help goes to a lot of those places. So focusing on public health, getting innovation, being part of the global economy with the technology and innovation in molecular biology and all of that, and genomics, being in Africa has been the best part of this story. And thank God that people still have sensitivity to people who are not as privileged. Getting the vaccine to people in Africa is so important and will be a game changer. I will protect all of us because people are beginning to think that COVID might just be a chronic illness that's here, like the flu vaccine that changes all the time. If that's the case, then we are better off investing now to ensure that as many people in the world get vaccinated so that we don't have pockets where we're going to continue to have mini epidemics that could spur another pandemic.
I have another, am I allowed another question, Dorian? Dr. Miller? One? Dr. Denny Zulu, on a totally different note, one thing I thought about a couple times when you were speaking is thinking about children, young and 10, 12, that sort of age, many of whom now have spent good chunks of their lives. I mean, for us, it's a long time. But when you're at 10 or when you're 6 and you've spent a year now potentially with a very limited group of people, or maybe only one parent, if what do you think when you think longer terms about the sort of socialization of children and how they interact with other children? What might be the effects down the road that of this period of really limited human interaction for some children?
Yeah. So I think I think we need, it's prudent for us not to put the burden on the child or the parent. It's what we do in those common spaces or those predominant spaces when kids return back to school, return to those spaces where they spend a lot of time. So it could be something for extracurricular activities. So it could be sports. It could be, anything that they may do after school plus schools. So like universities like us and other institutions like ours or community-based organizations, like literally that we flood the schools with resources and trainings for teachers and other people who work with kids. Again, I'm focusing on schools and out of school time settings because that's where kids spend most of their time. So again, the burden should not be on the family, but it should be on these different community-based spaces where we can then help train our professionals who work with kids on how to transition back. We're going to expect, like, some kids are going to have difficulty transitioning back. Some may not want to come back to school because they're so used to being home and they thrived well. Some kids have been thriving well. Like my seriously anxious kids are like, oh, I don't want to talk to nobody. This is really good. And I'm like, nope, you know, I'm gonna have you go back eventually. So, and we have some kids obviously who need to go back, but it doesn't, just because they're back in school doesn't mean everything is going to be okay. That we really have to focus on how do we transition these kids? How do we help them socialize? Because that's where a lot of that happens. Of course, some of this work happens within the home, that kids, you know, learn from their caretakers and their, you know, primary attachment figures, family members, like how to socialize, how to move about their world through modeling from experiences at home. But I feel like this cannot be a home issue. I don't want to even talk about home, because I really think we have to think broadly outside of the home. What can we do as a community to help these kids adjust? Kids are so incredibly resilient, and we have to capitalize on that and know that they're going to be okay, but they're only going to be okay if the adults understand that we have to do our job to make it possible for them to be okay. So it's up to us, it's up to the community to do that. So mentor, volunteer, you know, I think that all of those rates should go up, like people for Boys and Girls Club or the local Y, volunteer, because the kids are coming back, they're coming, and they're going to need some support, and there are people like us who can train people on how to do all of this, but we need the capital, the human capital, to make it work.
Well, and one thing that is notable about this experience is it is something that it is a collective experience. I mean, people will have experienced it differently, but it will be a point in everyone's lives, undeniable. So I think that with that, we need to bring us, I have a few closing slides. Do you see, wait. There, did I do it right? Yes? Do you see it? Thumbs up?
Okay.
Thank you.
Yes.
So with that, I want to thank Dr. Dini Zulu and Dr. Olopade and Dr. Miller. It's been such a pleasure to do this series with you. And I want to remind our viewers out there that they can watch the recordings of the previous sessions, that there is a conversation with Dr. Fauci upcoming. That is also a free event. We also have upcoming a film series. If you like this free event, but want something that maybe is a little bit more escapist, we do have a film series coming up that we're going to pilot, a new film series, and you can register for that. But mostly, I just really want to thank our panelists. I want to thank our audience. It's been a wonderful time to be here with all of you, and we've learned so much. And I appreciate the hope for the future and seeing a light at the end of the tunnel, which is really important. Dorian, do you want to have a few last words? Dr. Miller?
Thank you so much, Dean Osborne. Just thanks to my colleagues. University of Chicago Medicine really appreciates the opportunity to partner with the Graham School around this series, and also to thank our audience this evening for the questions that you've posed. We're sorry that we couldn't get to all of the questions. We tried to collect as much as we could and to share them, but again, it's been your engagement around this topic that I think has really brought so many of these conversations over the past few weeks to light. So thank you again, and be safe, everyone, and be well.